radiosurgery was regarded by most neurosurgeons. In fact, when I started training in radiosurgery, most stalwarts of neurosurgery regarded it as an alternative that they didn't really like. The biggest concern was that it would replace microsurgery. The evolution has been the exact opposite. So in my mind, there was never any controversy. Over time, what we have found is the best synergy. You choose what is best for the patient. There were many surgical procedures done at one time regarded as the only option for patients that often resulted in good tumor control but bad patient outcomes. What radiosurgery has allowed a neurosurgeon to do is to tailor those procedures to stop when it's safe for the patient and deal with any remaining residual tumor with radiosurgery. In small targets, we're able to completely eliminate open neurosurgery. And the word gamma knife really comes from that precision. We're not cutting, but we're cutting with the precision of a knife. 1/3 of a millimeter in the depth of the brain is about as precise as one could expect one's scalpel to be. The technical evolution of the gamma knife, which many people will tell you, has been around so long that it should technically be considered old, but nothing could be farther from the truth. What has happened in the evolution of the gamma knife is that the core principle, which no other machine has ever been able to achieve or better, is the high precision, 1/3 of a millimeter guarantee of hitting your target. And that has remained constant through all models of the gamma knife. And when you hear the word models, you realize there have been evolutions. So what has changed? What has changed is evolution in the way we plan the treatment, evolution in the way we monitor and deliver the treatment, precision coupled with semi-automation and robotic placement of patient makes the patient's journey through the treatment a lot smoother without interruptions and makes the operator's journey a lot more fluid. Gamma knife to this day remains the only planning platform in which you can seamlessly integrate CAT scans, MRIs, angiograms, PET scans, and even molecular imaging for prostate antigen today. What people may or may not know is that while immunotherapy is the new wonder drug of cancer, its effect and its efficacy dramatically increases when you combine it with a radiosurgical treatment up front. ZEP-X and before that the CyberKnife are technologies that use a single radiation source, a linear accelerator. In the case of CyberKnife, it was mounted on a robot. In the case of ZEP-X, it's mounted on a gyroscope. The gamma knife is using very small beam geometry, 192 simultaneously cross-fired beams. You can mimic that by using a single source and arcing it around the patient, whether on a robotic arm, in a CyberKnife, or in a gyroscopic setup as in the ZEP-X, but it is still a single beam, which means there's a finite limit of how many directions, angles of incidence, and crossfire beams you will use. So can you produce a very similar looking dose plan with both? Yes, you can. Now what happens is when you add all that complexity of moving the source around, verification of source position, guarantee of patient position becomes critical, something that the gamma knife inherently is built to take care of by fixed source, fixed patient geometry. That's one aspect of it. The other aspect is that the beam energy coming from cobalt is at 1 million electron volts, which has a very, very tight shadow, meaning what I hit is what I hit. Outside of it, dose falls very rapidly. None of the other technologies in the market can match that dose gradient. So what happens then is dose to target can be achieved by any of the technologies. It's dose outside target. And when we start talking of quality of life, patients surviving longer, patients with benign tumors living with the consequences of their treatment, the biggest impact is not just dose to target, but dose outside target. In fact, if you look, and ZAP is very new, there's only a couple of installations in the United States, a few in the European market, and now one in India, and probably a few more along the way. So the real problem is providing you an answer that compares clinical results of one to the other. We're talking more than 1 million patients with a gamma knife. We're talking several 100,000 patients treated with a CyberKnife. CyberKnife was always a jack of all trades, kind of brain, spine, a little bit of everything. The ZEP-X focus is back on the brain. But the reality is it's totally unproven. Now, do I expect, knowing John Adler, who designed it, personally very well, do I expect it to be a good technology? Absolutely, I do. Will it come close in some respects to the gamma knife? I'm sure it will, given the time. It's evolving still, its software is getting better every day. Will it surpass the gamma knife, or does it surpass it today? I don't think the answer to that can be a yes by any means, because the Gamma Knife still sits as the gold standard, because simplicity brings safety, and that's the key. The Gamma Knife may appear like a device that is very simple, but its simplicity has been timeless. We have had decades of successful treatment with very low complication rates as a result of that. The Gamma Knife radiosurgical innovation and its integration into microsurgery and the management of patients has had the biggest impact in the quality of life of our patients. For patients with large benign tumors who definitely require surgical debulking, the surgeon now has the option to debulk to a point where the patient is still maintaining function, but saved from the pressures and the life-threatening problems of a large tumor. That remaining small component of tumor can then be dealt with a Gamma Knife. Small benign tumors, patients can completely avoid the Gamma Knife, open surgery, which means days of their lives, admission to a hospital, and some of the ancillary risks that come with any open procedure. So the safety profile goes up. There was a time when once cancer got to the brain, you had no other choice but to use radiation. But if you used radiation in a large field like whole brain radiotherapy, you would cause significant damage to the brain. The longer the patient lived, the more apparent it would become that you had taken down their ability to remember things. They were not the same people anymore. And that quality of life loss was very real. It was not seen till we sufficiently improved chemo and immunotherapies and our patients started living long enough. When they were only living a few months, our treatments seemed reasonable, but completely had to be rethought of once patients were living years. Today, patients will live with their cancer, which means every intervention is only valuable if it A, controls the disease and leaves the patient, the real patient, the self of the patient intact. Most people don't realize, but healthcare systems where this is looked at very analytically and critically, an example is the NHS in England, where everything is paid through the NHS actually only allows Gamma Knife, only Gamma Knife for radiosurgery in children. Why? Because the lateral spill and collateral damage from other radiosurgery techniques out there is not considered safe enough for children who may have a 30, 40, 50-year lifespan, long enough to have consequences from low-dose exposure. Believe it or not, despite the fact that this uses the radionuclide, which often creates unnecessary fear amongst people, the amount of cobalt-60 in a Gamma Knife would fit inside a small salt shaker, and is actually the smallest amount of cobalt compared to industrial sterilization equipment that uses large quantities of it. And so it's a very safe device, and when managed properly, it's the safest for the patient, it's the safest for the operator, and there's minimal risk, if any, to anybody in society, and it's a self-shielding device.